Hi, I'm Dr. Krisa Keute, faculty member from the Department of Family Medicine and Behavioral Health at the University of Minnesota Medical School, Duluth campus, and family medicine, actually internal medicine physician at Aspira St. Luke's here in Duluth. I'm your host for today's episode on cancer prevention, diagnosis, staging, and grading, and treatment. The success of our program is very dependent on you, the viewer. So please call in with any question you have, send them to our email address at ask@pbsnorth.org. Our panelists this evening include Dr. Sandy Stover from the Department of Family Medicine and Behavioral Health at UMD, and Dr. Matthew Braithwaite, an oncologist from Essentia Health here in Duluth. Our UMD medical students phone volunteers are Simon Boyegna from Ellsworth, Minnesota, and Jessica Lawson from Hugo, Minnesota. And now on to tonight's program on cancer prevention, diagnosis, staging, and grading, and treatment. Welcome, you guys.
Well,
Thanks for being here.
Good to be here.
We always like to start with you telling us just a little bit about who you are and what you do. So.
Well, I'm Sandy Stover. I've had a career up the North Shore in primary care, so as a family doc. And now I have a chance to work with med students and do a little bit of some clinical work supporting them.
Very good.
So my name's Matt Braithwaite. I'm a hematologist and medical oncologist at Essentia Health. So I'm a cancer physician. Kind of what I do specifically is manage medications and drug therapies to treat cancer patients, and also see folks with different blood-related conditions, both cancerous ones and non-cancerous ones. So thank you for having me tonight.
Oh, it's so fun to be here. Hard topic, though, and one that concerns many of our viewers and our families and friends, because cancer affects actually so many people. I think about 25 to 30% of people will encounter a cancer in their lifetime, and maybe even more. But then often as we age, I once heard a statistic that 9 out of 10 cancer patients are over the age of 50, so it's a very common worry for those of us who are entering the later parts of our life. So I thought maybe we could talk a little bit about something that I've been hearing about in the news, which is something called a liquid biopsy. And I wondered if maybe somebody in the audience has heard about this too, so we could just kind of tell them what is on the horizon a little bit, and what it is used for, and what maybe will come in the future. Do you want to field that one, Dr. Braithwaite?
Sure, I can start with that one. So liquid biopsies are blood tests that can have a number of different uses in cancer care. For instance, we use them in my clinic sometimes to detect small amounts of circulating tumor DNA in someone's bloodstream. And we can use that information to look for mutations that might be amenable to certain targeted therapies or other kind of non-chemotherapy type medications. I think the other area where we're seeing them emerge is with cancer screening. And so, those same circulating fragments of tumor DNA that I might be looking for to look for drug targets, we could use those just to maybe find cancer to begin with. And so there are some commercially available tests now that can be used to kind of look for multiple different cancers with one single blood test. And I think that's something, Sandy, that you may be seeing, more so in primary care. And so I haven't seen a lot of it yet here in this area, but when I was a fellow, I was starting to see some patients that were coming in with tests that had been done by, other providers.
Well, I know there are some tests out there that are helpful in looking at people at higher risk because, like with breast cancer, the BRCA testing can help make it easier to know the people that we wanted to be a little more careful in terms of screening.
Right. And Dr. Stover and I would love to not have to talk everyone into a colonoscopy if it was as simple as a blood test. Wouldn't that be easy?
Although the Cologuard, which is one of the brand name for one of the tests that's out there right now, is actually pretty easy to do in a home setting, and it's increased the number of people that have gotten screening already. Yes. But a blood test would be even more so.
Yes.
If I can add one thing there, though, these tests will oftentimes come back positive, but then you have to go looking for the cancer. So you may still very much require that colonoscopy or other imaging tests or biopsies. So oftentimes that's just the start. So there are some other implications, I think, of this testing that the healthcare industry as a whole will have to figure out how to manage.
Probably behooves us to state that not every positive test is positively a cancer also. So that's important to put in our message about this exciting frontier on medicine. I do have some questions. Are you ready?
Excellent.
All right. Why do we screen for some cancers and not others?
Well, and I think that kind of goes to what we were just talking about. What does a screening cancer look like? And there are some cancers that will give some hints that there may be something going on, like breast cancer. The tissue of breast can be looked at with either X-rays like a mammography or ultrasounds, and you can see changes in the tissue in a different way than you could see something. It doesn't work that way to do special X-rays to the abdomen. CT scans can be helpful, but they're not specific in terms of densities. So there's different kinds of things that respond differently and have different outcomes. You probably have some input on that as well, I think.
No, I agree with everything you said. I think other reasons why some cancers might be easier to screen for or be more effective to be screened for, that you kind of have to think about what the downstream ramifications are. So ideally a screening test for cancer is going to detect cancer at an early stage where you can intervene on that and improve someone's outcome, ideally their survival, because we all worry about dying of cancer. That's people's ultimate concern, and so we need to be able to intervene to improve a patient's outcome. So colonoscopy, for instance, if you can find a precancerous spot in someone's colon, like a polyp, you can do something to intervene on that and hopefully prevent them from having a cancer that might affect their health in years to come. If you take something like pancreas cancer, for instance, it's maybe harder to find it in the first place, and to deal with something that might be precancerous might be a big invasive surgery or something like that, and so it gets more difficult.
Right. I think that's a good point. Some cancers we can find very early and treat and be effective at that screening tool, and others we just can't figure it out fast enough, and unfortunately it's not probably cost effective, nor with the numbers of folks that will have these cancers to endorse a mass screening efforts for them.
I think so. There's some things like skin cancer, though, that people can be alerted to what to watch for, which is sort of like a screening. It's not a mandated or a formatted sort of screening, but being aware of what does it look like when skin changes are normal with aging, and which ones are more concerning and need to go in to be checked out.
Yeah, that sounds good. I'm tempted to tell you to tell the audience what they look like.
Rapid change, anything that's uncomfortable, color change, irregular borders, increased risk in a family. People who have light skin are at higher risk. People who are redheads are at higher risk than blondes are. The shapes to some extent.
Yeah. Irregularity, yep. I think, denser color.
And variegated color.
Such a good
multiple
public
colors.
service message, Sandy. All right, I have a good one. So this is, they didn't leave a name, but it's someone who wonders, it's an environmental question, so such a good question. His specific question is about uranium and how that causes cancer, but maybe we could talk about other things that are in our environment in addition to uranium. And what do you think about things like that and how they might be risk factors for cancer? How should people consider that and where they live and how they test maybe their water, soil, environment?
In terms of environment, there's a number of things that we do in terms of the foods that we eat that may be more helpful in reducing cancer risk. With colon cancer, a lot of more of the fresh fruits and vegetables are easier on the gut and more healthy for the gut than eating things that have more preservatives and more things like that. So higher fiber diets are generally better for colons. I think we're just talking about skin cancer. Some of the radiation that we get from the sun, the UV light is essentially a radiation form that can impact the genetics or how the cell's turnover is going. Because cells are amazing. They turn over rapidly. They keep us healthy and things working well. But that process of continuous division relies on cells that are healthy, and that the genes or the plan is basically, I think of what the genetic materials, like the plans for how to make things within the cell. And if they're screwed up a little bit, it's like when you get that Christmas toy you're going to set up for your kid, and you realize that some of the pieces are missing, or the pieces are not the right piece for the situation, and it doesn't work then.
Right.
And so then you get abnormal turnover on the cells, and growth happens that's not normal.
Dr. Braithwaite, do you want to comment about uranium environmental factors?
Sure, yeah. Like Sandy was saying, different toxins or environmental exposures can sometimes damage the DNA in our cells. And sometimes when the DNA gets damaged, these mutations that happen in our DNA can cause cells to gain some sort of survival advantage, which is kind of a paradox, but can cause them to grow in an unregulated way. And our cells have these mechanisms that tell them that they should live for a certain amount of time and then die, just like our own bodies. And sometimes those mechanisms can get affected by things like, uranium or other things that cause some ionizing radiation or other toxins in our diet. And so, I think we need to be mindful of the things that we put in our bodies. It's a really hard thing to study. Figuring out what things are bad for us and what isn't is sometimes a difficult question.
Mm-hmm. So many things, but I do remember studying in medical school about radon, for example, and it's linked to lung cancer. Mm-hmm. And of course, you'll have a radon test when you buy a new home, and that's what's happening there, is like to look to see if your environment is a risky environment in which to live.
Well,
but
we
That's a
also
great
have
point.
lead in water systems that can sometimes get there. They're left over from decades of even lead in gasoline. That's still around.
Right.
Yep.
Sure.
Especially for Duluth in particular, being an older city with some lead service lines still, and so.
Infrastructure. Well, you use some words, and Krisa loves her history of medicine, so we might as well go into that. And so I warned these people, my guests, that we were going to talk a little bit about Peto's paradox. And so that is, do you ever sit around and think, like, why do we get cancer? And why do some living things not get as much cancer? And I've mentioned elephants before. It's my favorite organism to talk about on the show. So, for example, humans have a higher risk of cancer than elephants, but one wouldn't think that would be the case because elephants have more cells. And if you have more cells, like Dr. Stover was saying, each cell can have a mutation and it can mutate into a cancer. So why don't elephants who have more cells have more cancer? And that is it is something called Peto's paradox. So do you want to maybe talk to the audience about why humans have more cancer and certain things like beings like elephants do not, but mice, for example, have a lot more cancer? Maybe that's interesting.
That's a great question, and I was reminiscing on the fact that someone asked me that question when I was interviewing for my oncology fellowship, and it kind of took me by surprise because sometimes we're thinking more about what are we going to do about this cancer rather than some of these questions about its biology. But what you're alluding to is interesting. Yeah, animals that are larger have more cells. There's more cell turnover in the body, so more chance for mistakes to be made. So you'd think more cancer would happen, but that doesn't seem to be the case. I don't think anyone truly knows all the reasons why, but we do know that some really large animals, like elephants, have more genes in their body that can suppress cancer. So most living organisms have this gene called P53, which encodes a protein that helps our cells die if there are errors in its DNA, things that could lead to cancer. And we have 2 copies of that gene in our bodies, one that we received from our mom and one that we received from our dad. Elephants have 20. Mm-hmm. And so they have a genetic protection against cancer because of that. And there might be other things that contribute that too, but that's something that I think scientists have pointed to as an explanation for that.
Thank you. I just think that's so interesting that elephants have less cancer than we do. And you're right, it's all because of that P53 gene, suppression gene. Fun medicine. So, okay, this is a really specific question about a part of the body. Therese from Duluth asks, with a new diagnosis of Barrett's esophagitis, what is my likelihood of getting cancer? And maybe we could talk about how to monitor that to try and prevent cancer. So. Anybody want to field that one?
So Barrett's esophagus is a change in the cells at right where the esophagus meets the stomach, and the most likely reason for it to happen is irritation, ongoing inflammation, which increases cell turnover, which is problematic for cells. That some of those turnovers may result in abnormal appearing cells, and so constant irritation on that from reflux or from other things. If cancer were to develop there, it's hard to see it. So the benefit of doing regular endoscopies, or where a tube goes down, you can look and potentially take biopsies of that tissue, is very helpful. So the risk is one of those things that to say risk for an individual is difficult. To say risk for a group of people is less precise, but a little bit more likely. And it kind of depends on the degree of the Barrett's. I don't have that in my head and exactly what it is, but we generally see people with Barrett's have regular surveillance. So that's another good word that's kind of good to describe, is there's screening where we're looking for anything that could be happening in a number of different organ systems. So mammograms, colon screening, there's lung screening at this point, particularly for people who have a history of smoking. But when we're doing surveillance, we have something where we know there is already a change where growth may be impacted and some abnormal cells are showing up. And so you watch for them to get to that point where you need to intervene. Because as you had said earlier, sometimes if we go in and intervene too soon, the method we use to do that can be more damaging than the cancer itself. So going and removing a pancreas, because you might have pancreatic cancer someday, well, pancreas is pretty important in the body, so you don't want to do something that causes significant injury to those kind of major organs.
Yeah. And yet, I would say those who have genetic predisposition, sometimes we do
things like ovaries, removing ovaries,
right,
or doing a prophylactic removal of a breast. If people have the BRCA gene. Yeah.
Such good conversation. This is another great question from Tom from Duluth. He asks, why would CT scan MRI be beneficial for watching for or screening for cancer?
Yeah, I can take a stab at that one. So in general, a cancer might show up as an abnormality on an imaging test, like a CT scan or an MRI. So a couple examples of that would be using a CT scan to screen someone for lung cancer. That's something that we do commonly in patients that are at high risk for it, so namely people that have a strong smoking history. And the rationale of that is that you might find a cancer in early stage and it appears maybe as a small nodule on that CT scan. And if that can lead to a biopsy, then that proves that it's a cancer. It could be operated on or radiated at an early stage before it becomes more advanced. Similarly, with an MRI test, that's something we may use in certain patients that are at higher risk for breast cancer. It's a bit more sensitive than a mammogram, so some patients that have a high risk based on family history or genetics, like a BRCA mutation like you were mentioning, an MRI of the breast might find a very small or early breast cancer that could be intervened on early.
Good. On occasion, I will have a patient refuse a test because of their concern about exposure to radiation. And we use radiation to screen. Mm-hmm. And so I always find myself in this predicament of trying to explain, like, the amount of radiation exposure might be worth the risk for trying to detect an early cancer. An example of that would be regular mammography or the low-dose CT scanning. Could we speak maybe a little bit to radiation exposure and how much to worry about that? Sometimes as a hospitalist, I think, whoa, this person had a CT scan a month ago. Should I do another one? How much radiation should I expose them to? Can we have a little conversation maybe about that?
I talk to people a little bit about relative risk, and what that means is what's the risk of doing something versus the risk of not doing something. And it's interesting that we receive radiation every day from the world around us, particularly from the sun, but there's other sources. And so when we go on an airplane and fly across the country, it's about as much radiation as a chest CT, if I remember the correlation, something like that. And so it's like, but I don't, we also don't want to do so much exposure in a natural world that we, that you would have to take that into account too. But I think that the balance is an individual decision relative to the risks an individual has and the benefits of doing an intervention is the big thing. I think it's also important to understand that frequent radiation at a younger age, where the ability to form eggs and sperm, and those kinds of things would be more impacted than radiation at an older age, although at an older age we've had more accrued radiation. So it's one of those, the students that I work with get tired of me saying this, but it kind of depends. There's individual choices, and that's something, though, to understand that in that balance, it may be better for you to have some radiation to understand the disease better, even though there's some risks associated with everything we do.
Right. We really value life, and we're just trying to prevent an illness, and so sometimes the risk is worth it. If we catch things early, why else would you come to the doctor?
And sometimes it's just understanding it better. If people understand what's going on, that can be so valuable, and to have a better grasp of the choices that they have.
Right, exactly. Here's one about prostate cancer. This is a fun cancer to talk about. In truth, like, this whole topic is so vast. We could spend
a week.
We could be on TV for a week. Anyways, wouldn't everybody love that? Okay, it says, among cancer patients, even though they have the same disease, why do they have different treatment regimens? So I'm going to let you answer that.
Sure. So cancers that arise from different parts of the body oftentimes have different biology. There's different things that drive the growth of those cancers. And because of that, they may be more sensitive to certain types of treatment. I think you had alluded to prostate cancer. We know that the biology of prostate cancer is such that testosterone in particular seems to feed the growth of that cancer, at least early on in its disease course. And so we find that taking away testosterone can prevent those tumors from growing. That might be very different from someone with lung cancer or somebody with pancreatic cancer, where different things are driving the biology or the growth. And so in general, it's this biology or these genetic changes within the cancer that are driving it, and we sometimes need to use different treatments because of that.
I've found in my career, I've seen the evolution go from trying to target the cell, the malfunctioning cell, killing that, to trying to enable our own immune system to fight the cancer. And so it's been a very exciting change over time, I feel like, in terms of what we're seeing as far as options go to treat. And so each patient is unique. We certainly study them genetically. We look at the cancers and how they're made, and try and formulate the right concoction to beat the cancer. So, well, that's very good. Let's see. I'm trying to think of other commentary about that. I'm sure go ahead.
Well, I think what you touched on about immunotherapy, I think that's one of the more exciting things in our field right now, something that's really revolutionized cancer care in the last decade or so, is our understanding of what the immune system does to both prevent and how we can utilize those aspects of the immune system to treat cancer. Because we see, for example, that people that are immunosuppressed have higher rates of cancer. So for instance, folks that have had maybe an organ transplant, they're on immunosuppressive drugs. Because of that, they have higher rates of cancer. So we've known about this correlation for a long time. But currently we have some medications that allow our immune system to better recognize cancer as something that shouldn't be in our body, basically helping the immune system do its job and go after cancer cells and try to get rid of them.
It is definitely part of our job that is up and coming. Some of the most interesting new treatments that we have in medicine surround cancer. I'm from a small town, and I've often heard questions from friends, family, about whether we have a cure for cancer and we're just withholding it. You've got to love a good conspiracy. I know that sounds a little crazy, but I've heard that more than I could believe. And no, we don't have that, and I wish we did. I'm sure if we did, we would give it to everyone, because in medicine
I think it does bring up that we have reached a point where there's vaccines that can really help reduce some of the cancers that are triggered by certain viruses, like the HPV virus.
Yes.
And so
hepatitis B.
Hepatitis B. Yep.
Yep. Thank you for that. That's a good memory thing to remember, I guess, when so we have prevention, we have screening, and then we have detection and surveillance, I guess. So, Well, we're nearing the end of our show, and I just want to, first of all, invite you back. You are wonderful guests, very interesting, and I enjoyed your commentary. Do you have any final thoughts for our audience today on our cancer screening treatment?
I think the big thing is there's lots of changes, and it's because we're getting better and better evidence on what to do. So it's not that we change our minds about something, but it's about there's something better to do. And so the recommendations do change over time. The screening that your doctor will talk with you about might be a little different than what you heard a couple of years ago. It's because we're getting better at it.
Yeah.
Yeah, thank you for having me this evening. I'd maybe for a parting thought just say that please come see doctors like Dr. Stover in primary care so that you can prevent the cancer and maybe not see me in my clinic and need my services. But cancer is an unmet need that we all need to continue to work on to take care of patients in the best way we can.
Thank you for that.
Yeah.
I want to thank our panelists, Dr. Matthew Braithwaite and Dr. Sandy Stover. Please join Doctors on Call next week where Dr. Radon Harden will discuss care and treatment of the upper extremities, shoulder and neck, including muscle and tendon conditions, joint replacement options, and prevention, with a panel of experts from around this region. And if you're looking for more tips, tricks, and conversation around health and wellness in the Northland, make sure to check out Northland Balance on the PBS North YouTube channel. Thank you for watching and joining us for season 44 of Doctors on Call. Good night. Happy holidays. Promos.
Are they just like broadcasts?
I guess. I know some of the nurses, and thanks you guys so much. What a wonderful discussion.
Yeah, it should be
Yeah.
an hour one easily.
Yeah.
because there's so many, especially if you kind of.
We didn't get as many questions as we normally do, but
You did a nice job.
The phone lines died, I think, halfway through, from what I was hearing.
really.
Yeah, so Jason was going back and forth just.
Oh, shoot. Okay, that makes sense because we normally have more. They were great questions, but yeah, I just sort of punt and.
Thanks
No, I
for,
think